Good morning again. It's 11 o'clock, so I will call the meeting to order. Once again, good morning and a great 2022 to all of you. We do have a quorum, so we'll proceed to item number 2, which is disclosures of pecuniary interests. If anybody has any disclosures to make at this point in time, please do so. I see none, so if an item arises throughout the meeting and where there is a conflict of interest, I would, of course, counsel you to raise that conflict at that point in time. So that gets us to item number 3 of today's agenda, which is the nomination of this committee's chair for the next year. And I have Councillor Veen who wishes to speak to that.
Yes, thank you. I would like to nominate Dave Ferguson as our chair.
All right. Do I have a seconder on that? I have Councillor Rombouts as a seconder. Is that correct? Thank you. And Councillor Ferguson, do you accept that invitation? I see you nodding, so I'll take that as a yes.
Yes.
Thank you. So I have Councillor Veen, seconded by Councillor Rombouts, to nominate Councillor Ferguson as chair of this committee for this year. Let's proceed to a vote. All in favor? It looks like it's unanimous. Congratulations, Councillor Ferguson. I will pass the meeting over on to you to proceed with the nomination of your vice chair.
Good. I'd like to thank my nominator and the second nominator. This will be a new experience for me, so bear with me as I move along. And thank you. And now we have to move into appointing a member to the Lambton County Accessible Advisory Committee for a 1-year term, 1 member. And has somebody done this before? Oh, sorry, let's do a vice chair.
Correct.
Sorry about that. And I'll take nominations from the floor for a vice chair, please. Jackie, go ahead, please.
Thank you, Mr. Chair. I'd nominate Councillor Doug Cook.
Brian White, your hand was up first. Thank you. Second nomination?
Yes, sir.
Any further nominations? Seeing none, I'll ask Mr. Cook if he will stand for that position.
Yes, I will. Thank you.
Thank you. So we will call a vote. It is only 1 nomination. We'll call a vote. All in favor? Thank you. And unanimous. Thank you. Now move into the County of Lambton Accessibility Advisory Committee, a 1-year term for 1 member. Has anybody done this in the past? So go ahead, Doug, you've been on it. What's it entail? We could ask that question first.
Actually, the committee we're supposed to meet a few times a year, but with COVID, we haven't been meeting much at all. I did meet at the beginning a couple times. We've just been updating the long-term plan that they have. That was the last update that we had. And I would be willing to stay on the board for at least till the end of the term anyway.
Thank you. We will now open the floor up to nominations. And if anybody wishes to state an interest, please maybe declare so now also. Go ahead, Ian.
That being said, I will nominate Doug for the position. I think if he's already doing it, I think he might as well finish the year out, I would think.
Thank you. Can I have a seconder for that? I see Brian White had his hands up, seconding the nomination. Any further nominations? Seeing none, I'll call the vote. All in favor? Thank you. Carried. Unanimous. Now we move into Dr. Ranaday. Is he on? I'd have to see. There he is. Thank you. You have the floor, Doctor. Thank you.
Thank you. I'll just confirm, as always, that you can hear me.
Yes, we can.
Great. And I'll just ask the administrator to allow me to share my screen with you all. There's a lot to talk about, and so I tried to structure it through a presentation as I've done sometimes in the past, just because there's a lot going on that I wanted to update you on. So hopefully this should work, and you should be able to see my screen instead of... Can you see the screen?
Yes.
Okay, perfect. Thank you. So good morning, everyone. Lots to talk about today, and I really just want to give you a sense of kind of where we are right now and where I think we're headed in the next several months with COVID specifically. So we'll talk about the local and provincial situation and the impact of the cases and that situation on the other activities within both the public health and the healthcare system. So the changes to case and contact management, the changes in the health system or the impacts there, the changes to testing, what's happening with vaccination, a few updates on treatment developments, and then walk into sort of where we think things are going to go moving forward. So this graph, I've pulled this graph directly from our Lambton Public Health website, and it shows the sort of the 7-day average of cases over time since the beginning from April 2020 to now, January 2022. And the dark blue bar, if you can see that, and I'll follow it with my pointer here, is Lambton County, and the light blue bar is Ontario. And so you can see right now that Ontario and Lambton County are tracking fairly closely in terms of an upswing and what looks like a downswing, but we'll talk about that in a second. The most important point that I want you to take from this graph, and this is why I've drawn this line here, is that this line represents the peak of cases that Lambton County has had, and that was back in January 2021. And you can see that the cases that we have now are many times that peak, right? They're many times higher, the level of transmission, than the level of transmission that we had at even the highest wave that we've ever had in the past. So that is largely a reflection of Omicron, and we'll get into that in a second as well. But that is the main point here. And when you translate this over to the province is seeing a similar situation. So I've just isolated the provincial data here, and this is from Public Health Ontario, that when you move from 2021 into 2022, the highest levels that the province saw that were sort of in this area, sort of April, early May, 2021, many times higher levels of transmission and cases that we're seeing now in 2022. Right? And so that's the important piece to remember here. That kind of transmission is very widespread, and it is very fast. And it is, so the key point here is that the transmission of COVID is many times higher than any previous wave. This is driven by the Omicron variant and its transmissibility. When I go back very quickly, just for 1 second here, I'll go back and show you that it looks like case numbers are falling down very quickly as well. It's important to remember that that is probably in the short term an artifact. And what I mean by an artifact is that it's something that shows up in the data that is not necessarily accurately representative of the cases, because there have been significant changes to the testing eligibility. And with reductions in the eligibility for testing, there are fewer tests being conducted and therefore fewer tests that are available to come back positive, right? So that coupled with the high transmissibility of Omicron, which the thinking for that right now is that for every case that we know of COVID, there are 4 to 6 cases in the community that are undetected. So when you put those two things together, what that means is that the current case counts significantly underestimate what the true incidence of disease is in the community, right? That has implications everywhere. That has impacted our public health contact tracing system. It's impacted testing. It's impacted in terms of case numbers, the hospital and acute care sector. So let's focus a little bit on these different parts. So in case and contact management, that has driven us as a system to focus more on case and contact management in the highest risk settings, which are acute care, long-term care, and some other congregate settings. Those are the current focus of case and contact management. It's important to remember that that also comes with a change in purpose of case and contact management. We are no longer using case and contact management to actively control disease transmission, but to mitigate the impact of that transmission in highest risk settings. So that's an important piece because it changes the reason why this is happening in the first place, right? When there's so much disease around, case and contact management is not an effective tool to really reduce the transmission of the disease. When there's less of it, you can use case and contact management effectively. And it's also resulted in changes to the isolation guidance. So currently that guidance, as well as all of our other guidance, is changing rapidly. And right now, all of that guidance is in a state of flux, I would say, between a position that is related to controlling transmission and a position that is related to mitigating the most severe impacts of transmission, right? And because the guidance is in flux, that results in a lot of situations where the guidance itself is impractical and sometimes unfeasible. So here's one example. Right now, we definitely advise that anyone with any symptoms should presume that those symptoms are COVID and self-isolate. But the current guidance also suggests that everyone in that person's family has to isolate as well for 5 days, and that 5 days renews every time someone else in a family gets symptoms. But we all know how diseases track through a household. It's not that everybody gets it together. There are a few situations where that's true, but in general, with respiratory diseases, it goes from one person to another to another to another. And if you have 5 or 6 people in a household, the current guidance or the expectations around that guidance would be, that household might be then isolating for 20 or more days, which is not practical or feasible, right? So you move back to a situation, especially when you can't even test those people and you don't even know that what they have is COVID. You have to move to more practical places, which is things that we used to do before COVID. Like if you're not well, you stay at home. If others in your family are well, they may carry on with their lives, right? That hasn't made it into the guidance yet. So you'll see lots of trying to navigate how does this work with different systems, the school system and the healthcare system, et cetera. But over time, I think that guidance will move to a place where it acknowledges that the core purpose here is not reducing transmission, but mitigating the impacts of transmission. Okay. In the health system, we've seen an increase in hospitalizations. You've seen news reports that Ontario and Quebec have logged their highest hospitalizations ever through this pandemic. The important difference here is that right now, the largest pressure in the hospital system seems to be not related to the ICUs and more related to the regular ward beds, people needing 2 to 3 days of admission with COVID related to, not necessarily requiring ICU level of care, but just requiring additional care and management for a few days before they go home. And that in addition to backlogs in getting people out of the hospital are causing sort of system level issues there, in addition to staff shortages related to their own illness, people being unable to be at work because they are ill. The other health system initiative, although I'm told that that's easing up, that is actually those hospitalizations are increasing at a lower rate. The other initiative in the health system that's important to be aware of is sort of a shift from just sort of testing centers towards more assessment centers, where people who have symptoms can go to these assessment centers and be clinically assessed. They may be tested if tests are available or if they're eligible, but if not, they'll actually be clinically assessed. And then over time, as we get more treatments provided with particular kinds of treatment, right? I think we have to now start imagining or envisioning that we will experience ongoing peaks and valleys in COVID admissions to hospital over the next several months, plus that the acute care system is going to be balancing the backlog of surgeries and procedures that have been delayed over time, right? So that's the balance that they're going to be continuously trying to strike over the next several months about maintaining beds for people to be admitted while also moving forward with surgeries, et cetera. Right now, they can't because there's a directive against it. But when that directive is lifted, they'll be able to, that's the balance that they're going to move into. Testing eligibility for PCR testing has now been narrowed towards those at highest risk of severe disease, those who live or work in highest risk settings. And what that does right now is that gives us a far less comprehensive picture of the disease, right? When you're only testing people who are at highest risk of severe disease or only testing people in settings where they're receiving care for symptoms, the picture of the disease is skewed towards greater severity. So we won't have the large surveillance system or comprehensive testing to understand the prevalence of disease or the incidence of disease. But that's in line with moving the goalpost to mitigating the impacts rather than managing transmission itself, right? That's going to be a hard one to move through with the community, because I know that there have been lots of people who've been saying, well, I need to know the numbers. I want to see the numbers. The numbers help me make these, various decisions about what to do. And we won't have that. The larger piece here, though, is it's right now it's widespread. And even over time, if it's not widespread, the risk of it will be prevalent among the remainder of circulating viruses, right? So, but we are going to sort of lose that comprehensive picture that we had on disease with the level of testing that had been happening. I'll move to a slightly warmer, happier part of the story. In terms of vaccines, I think that vaccination effort has been really tremendous. Middlesex London, our neighboring health unit, is recently reporting the achievement of a million dose milestone. And this week we're on track to reach a 250,000 dose milestone. And I think that that's reasonable based on our relative population sizes, right? So we'll surpass this milestone likely this week. And we've had about 77% of the eligible population with 2 doses of vaccine. And that is distributed well, I would say, in terms of the people who are at highest risk for severe disease. So we have great coverage in the higher age populations. They're at higher risk for severe disease. That coverage starts to drop as you reach lower age populations who individually or in groups at that age level are at lower risk of severe disease in general. We've increased our delivery capacity for vaccines throughout January in public health clinics as well as pharmacies and healthcare. So we're at the place where we can do about 10,000 give or take a week. I think last week it was 11,500. It just depends on the week, but that's quite a substantial increase from what we had been doing in November and December. And it's to get through the demand for boosters. And so I expect that through the rest of this month, we'll have very, very full clinics, but that demand for boosters will start to wane after that. And remember, in terms of what the vaccines are showing that they can do, you get really good protection against hospitalization and severe disease with 2 or 3 doses, and initially good, but subsequently waning protection. We think it's about 10 to 12 weeks against any symptomatic disease. And we know that. We've seen people who've had 3 doses get symptomatic disease. The key here is that we're trying to prevent hospitalization, severe disease, and death. And the vaccines seem to be holding up really well at doing that. Once you start to have that understanding of what the vaccines are doing, it necessitates a pause and a shift in the goals of the vaccination program, right? So we have to start thinking about moving away from using the vaccines as an effective means of reducing transmission and more to providing individual protection for people who are at risk of severe disease. So what was true of Delta no longer seems to be true of Omicron, right? And that we have to incorporate that into our planning going forward. Health Canada recently approved Paxlovid. I think that was approved just yesterday or the day before. That is an antiviral outpatient treatment for mild to moderate COVID disease. So this is not for people who are with severe enough disease that they need to be hospitalized. It's for mild to moderate disease. And I don't have any current information on how this will be rolled out. It could be rolled out through the routine mechanisms by which we generally get prescription medications, or there might be an alternate or parallel system developed to distribute Paxlovid as it becomes available. I don't know. It's also possible that if there isn't enough, then it'll have to be allocated to those who are at greatest risk of severe disease first before it gets sort of made generally available. So I don't have any information on who will be eligible at this time. Remember, it is not... I don't believe that it'll be an over-the-counter medication. Like when I look at the product monograph, it looks like it has a number of different contraindications, a lot of different interactions, and so we'll need a clinical assessment in order for Paxlovid to be prescribed, is my anticipation of how that would work. So I don't think you'd be able to go to the pharmacy and just pick up Paxlovid because you have a headache and you think it might be COVID. You'd need a clinical assessment, and then if you're eligible, they would prescribe you Paxlovid, and that would be made available. But again, that's in the future. We're still, as I get more details about that, I'll be able to share it with you. I think the biggest part here is, where do we go from here, right? We've been doing this for 2 years. The context now is very different from the context a year ago. We have a largely vaccinated population. That means the risk of severe disease at the population level is much lower, although you will hear reports of people with severe disease. But again, in a vaccinated population, that is happening less often. But also, the Omicron variant is presenting itself as on average less severe. So not that it never causes severe disease, but it seems to be less severe in terms of its relationship with other variants, right? So we know that long-term restrictions are going, they may reduce the transmission over time, but with such a rapidly transmissible variant, we also know that many or most people will be exposed to COVID-19 over the next several months. That is not a new message for this audience, but it is a challenging message to move through the public domain, right? WHO Europe estimates that about half of the European population will be exposed in the next 4 to 6 weeks. And that is consistent with a lot of modeling that is showing that this disease will sort of establish itself at a baseline level and be normally circulating through the population the way other viruses do. This is a point of awareness. I know some of you might have heard this presentation before, so bear with me. I'm almost done. This is a point of awareness for the group rather than a local action item, because this is not local work, but it's important that we maintain global variant surveillance, right? That's critical to our ongoing response to the pandemic, because we need to know if there are variants that are circulating that are more severe or less severe, and how they operate, especially with a global population that has not had the same access to vaccines that our country has had, right? That's very important. There are likely to be other variants circulating at this moment that we do not know about, and it's important to maintain surveillance so that we can assess that risk as we discover those variants. And now we move to figuring out how we live with risk, right? Because this is not, I've talked about this before. This is a delayable risk, but not an entirely preventable risk, right? So we're moving towards symptomatic diagnoses, the presumption of COVID if you have COVID-like symptoms until we reestablish testing parameters, right? And the understanding that very normal interactions between people over the next few months are going to result in COVID transmission. And we're going to have to start treating COVID as part of a normal circulating set of viruses because Omicron is forcing us essentially to do that. But that the context is different now that you have a largely vaccinated population and also increasing or improving treatment options, right? So that really does change the burden of disease that's experienced by the population and therefore the management strategies that you have to use to deal with COVID. So that was a lot, but there is a lot going on, and so I'll pause there and I'll leave it there and thank you.
Thank you, Dr. Renaday. I'll ask one quick question, and I'll move to Brian White as his hands up. So the people in the ward beds now for 2 to 3 days, and hearing about the Paxlovid coming down the line, the clinical assessment, could that be done online with clinical assessment to get a hold of the Paxlovid to not have people hit those ward beds?
It's possible. Right. So there's 2 ways that this could work. One is that you need a definitive COVID diagnosis in order to access Paxlovid, which might mean, the use of rapid testing in healthcare systems to try to see, is this COVID? So let me take you back to another way in which this might work. So some primary care providers, but not all, have been using rapid influenza tests for a while. Right. So you go into the clinic, you get assessed. And then if they think that you might need a rapid test for flu or for strep, you can get that. And then if that test is positive, then they'll put you down a particular treatment path. So if it's decided that rapid tests are a reasonable way to go on this front, then if you would go to an assessment center and you had clinical symptoms that were looking a little bit like COVID, they would give you a rapid test. If the rapid test is positive, and you were eligible, you'd be offered treatment for Paxlovid, right? Could that be done remotely? Yeah, possibly, right? But a more likely scenario is that you would need to actually see somebody to do that clinical assessment, listen to your heart and lungs and check your temperature and things like that, and then decide, do we think that this is COVID or do we think that this is something else? But that is one option. It could be virtual as well. That would probably result in greater administration of the medication because you're not really sure at the time, and so you want to allow for a treatment to happen, even if so lots of details to be worked out around that. I'm not really sure how it's going to play out. Good,
thank you. Councillor White, you had your hand up, please.
Thank you, Chair Ferguson. Thank you, Dr. Renaday. Just two questions. I'll just kind of roll them out at the same time. So prior to Omicron, this shift that we're seeing now in strategies, was it sort of like a plan B? You were prepared to roll in this direction should something like Omicron have presented itself, or was this sort of catching folks off guard and you had to quickly reassess your strategy and move in the direction that we're heading now? And secondly, am I understanding correctly that effectively what we're waiting for now is to sort of get over the hump of this surge in hospitalizations so that we can then somewhat normalize this disease and the spread of this virus and essentially resume life as perhaps it was once considered reasonably normal?
Thanks, Councillor. I like all of those things at the end there. So let's go with the second one, and then we'll go back to the first one. And I apologize if I forget the first one in the process of answering the second one. So nobody knows how this is going to play out, right? I think that if the expectation is that many or most people will be exposed to COVID, then what that is going to do over time is result in a significant number of waves like this. Each successive wave will probably be not as high as the first, but in order for it to circulate through a large part of the population, you will get this kind of scenario happening over time with waves. We may not even be able to detect it based on the amount of testing that can be done at that time, but that's typically what you would see. three. In each wave, you have the potential for a large number of people to require healthcare, and then for those people to be treated and leave the system, and then that wave goes down, and then, right? So I think that's from the health system side, they're probably going to be dealing with this for many months. That's not unusual. They deal with it seasonally anyway, but they're just going to be extending that work to deal with it over the next several months, right? That's one possibility. The other possibility, and it's just far less likely, is a massive upswing, a massive downswing, and then you don't have any more disease circulating that, as much because it's gone through most of the population in the first wave. That's less likely to happen right now. In the places that we've seen it happen, it was because many people had been previously exposed to another version of COVID. So in South Africa, it was estimated that I think 90% of the folks had already been exposed before Omicron showed up. And the wave was one big one, and then it was done. And I think in other places, you'll expect to see more like this. Sorry, I have actually forgotten your first question.
That's okay. So the question was, prior to Omicron, was this shift in strategy that we're now seeing expected and planned for, or did you have to pivot on a dime once Omicron swept across the globe?
I think that there were some things we knew were going to happen. We always knew that there were going to be different variants, right? As soon as we started to see alpha, beta, delta, whatever, we knew that the variant thing was happening. We knew that there were going to be more and more variants. The question was, are there going to be variants that are more transmissible and less severe on average, like Omicron, or are there going to be variants that are more transmissible, more severe, or less transmissible, et cetera, right? Those are the questions that we don't know. Omicron, I think, is pushing us to a place where we probably needed to be anyway, which is how do you integrate this respiratory virus into the way that you deal with other respiratory viruses, right? So because of its transmissibility, because it's less severe on average, and because most people are vaccinated, you can move to a place where you're starting to deal with it like the other things you deal with. Was that always part of the strategy? I think it always had to be part of the strategy. It just depended on when it was going to happen. Was it going to happen at year 3, at year 2, at year 1, right? So in some ways better now than at year 3, but and better in a largely vaccinated population than a completely naive population, immunologically naive population.
Good. Thank you, Doctor. Ian Beans has his hand up next. Thank you.
Thank you, Chair. To Dr. Renadade, I was just curious, how long is the average stay in the ICU? Is it like a week or 2 weeks, or can you give an idea how long people are there?
Sure. And I would say that it's different now than it used to be. So there's been 3 kind of distinct waves of ICU admissions. In the first wave, it was elderly people in the older age ranges who would be in the ICU, but for a short period of time because they either recovered quickly or they didn't. Right? The second wave of ICU admissions was largely younger people, and because their immune systems and their bodies were more robust, they actually stayed longer. They were on treatments for longer and took a longer time to recover because, more of them made it, but they stayed in the system for 6, 8 weeks, et cetera. And it's a long time to be in the hospital, right? This is a little bit different. And what we're seeing is that the average time in the ICU is much shorter, but it actually is probably diverged into 2 groups, in that there are people who have very, very severe disease that look like that first wave, right? And so they're either in and out very quickly because they either make it or they don't. And then there's another group of people who is in there for a bit longer. They're likely to be sort of younger, unvaccinated, similar. So it's both of those things coming in together, which skews that average, right? So it's kind of a variable picture now in the ICUs.
Thank you.
Thank you. Additional questions? Mayor Rombout, go ahead, please.
Thank you, Chair Ferguson. I'm just wondering, we've spent 2 years getting the whole population really afraid of this illness. And now, based on the report that you just gave, we have to kind of pivot and change that mindset. Do you see the provincial government moving towards that as well, so that people can start to calm down? I'm seeing a lot of mental health issues in my community based on the fact that on both sides of this, right? There's people who are still extremely afraid of this as a virus and believe that, you know, if I get this, then I'm going to die. And then you've got people on the other side who are very much against it. Like, it's just, I'm wondering when the information is going to start coming to the mainstream that, yes, this is a serious illness. Like, we don't want to diminish it, but at the same time, maybe we shouldn't live in this high state of fear all the time, because that's not very healthy either.
So yeah, thank you, Councillor. I agree with all of that. I think that it is the biggest challenge is to now move people toward this idea of living with risk. I think for a long time, people have been divided into there's 100% risk or no risk, and neither of those positions was actually very tenable, right? The truth is that there is some risk, and that there are some situations where that risk needs to be managed more than in other situations. I think there's some additional complexity that's created by, the difference between what's happening at the population level and what we see, and the story of any one individual, right? Because there will be cases in the ICU, and we will still hear about those. And that tends to skew the perception of the disease towards the worst case scenario, when what you see in the population is not always that worst case scenario, right? So the biggest challenge has been to navigate that sort of like, well, this is what we see on average, but sure, in any given case, it could be more or less severe, right? And then navigating organizational responses to that. So, you're right. You cannot live in a state of fear for this long. It is that kind of chronic stress is actually incredibly unhealthy and really bad for long-term chronic diseases and other impacts. We know that. But getting people to move off of that adrenaline is going to be really challenging, right? They've been used to this sort of tension for 2 years, and we have to work with them now to help them understand that yes, there's a risk, but we've got a bunch of additional tools help us to bring that risk down to something that, when you put it against other risks that we face, is much more manageable, right? So we'll do our best. We'll keep moving forward with that. The current provincial piece is challenging, right? And I've told you that the guidance is in flux between the idea that we have to control everything and the idea that we have to mitigate the impacts. And the reason for that is because of the sort of stakeholder dynamics at play, right? You don't want to be seen to just be, throwing it all away, but also, so that's the part that's being navigated right now. But I think, the more we can be practical about it, the better. And the more we can be reasonable about it, the better. And so practical and reasonable is when you're not well, you stay home. You take the steps that you need to protect yourself, which include getting vaccinated and not being around sick people and so forth. But there is a place in time at which we have to recognize that normal social interactions are really driving the path of this disease. And so how long can people avoid normal social interactions for without significantly damaging the other aspects of their health, right?
Thank you, Doctor. I'm going to throw a little plug in there that there's an employee of a farm organization or farm business in the county is putting together a mental health seminar, and I'm not sure going to be in February or March. I won't say the name, but if we wish to have anybody know out of the farm communities, contact me and I can pass the organizer's name on, for that will be happening. And we don't have dates yet, so I don't want to throw the name out in public. Contact me and I'll put you in contact with the person doing the organizing. Any more questions? Seeing none, I will thank Dr. Renaday for his time today, and we hope to get some other relief in the next week or two with some openings up. We do hope to see that. Thank you, Doctor.
Thank you.
Now we'll move into the long-term care division. We have correspondence 6A. I'm going to ask for a motion from the floor and a second to receive and file. Then we will have discussion before I call the question. Can I have a motion to bring this to the floor, please? Steve Miller and then Jackie Rombouts. And now we'll open the floor for discussion. I see Jane George on for any questions. If there's no questions, I will call for the question. All in favor to receive and file? Sorry. Thank you. Carried. Move into 6B, information reports. This will be a COVID update, A, B, and C. A motion to bring this to the floor for discussion. Mover and a seconder, please. Ian moves, second by Brian White. Questions, please, discussion. Go ahead, Councillor Cook.
Thank you, Chair. Just item C, the modernization report. I could appreciate that right now the most challenging departments have to be long-term care and public health. And I sympathize with the managers having to try to modernize everything to get their schedules fixed up. Is there anything out there right now? Are you aware of, Ms. Joris, that the government's looking at maybe incentivizing some more of these opportunities to get people into the programs to up the numbers so that we can get more PSWs and that in?
Through you, Chair Ferguson. Thank you, Councillor Cook. We yesterday received information about a staffing pool that the ministry has implemented, and there's a webinar tomorrow. I believe it's internationally trained nurses who are not yet registered in Ontario, who can work as unregulated professionals, and homes can apply to have those folks come and work. The ministry is continuing with the accelerated PSW program, some changes to the training for nursing and personal care. So there is some work happening. It takes a while to get people trained.
Okay, thank you.
Any other questions for discussion? And this will just be a receive and file. All in favor? Carried, thank you. Move into the corporate service or any other business under under their long-term care.
Chair Ferguson, I just would like to bring to people's attention that the COVID-19 outbreak at Marshall Manor ended today, and the staff have worked diligently there to work through that. So currently, none of our homes are experiencing an outbreak.
Excellent news, thank you. I'll now move into corporate service division. This will require a motion. So I move in a second to bring it to the floor, please, and we'll have a discussion. Moved by Steve Miller. Second by Ian Veens. Discussion. I do have one question. In the service and fees, I see that there is a fee for $100 for refreshments at the museum. Did I see that? Do I get the whole bottle for that?
Thank you very much for that question, Chair Ferguson. I'll let Andrew Meyer, the general manager for that division, respond to that.
Thank you.
I understand he's on the line.
I think we caught him flat-footed.
Apologies there. I had issues with my video. Sorry, Councillor, could you repeat the question regarding refreshments?
The $100 refreshment fee, is that the good stuff, and do I get the whole bottle?
Great, that's what I thought I heard. I think there may be an error, and I'll look into that and report back. I apologize.
I presume that is if you're going to hire a bartender, is what that will be. Thank you. Any other questions for the fee schedule? All in favor? Thank you. Carried. Other business under this division? Hearing none, we'll move into finance, facilities, and court service division. And we have a Bayside Center activity report and a report attachment. I'll have a mover and a seconder to bring these to the floor, please. Moved by Doug Cook, second by Brian White. It's on the floor. And Mr. Brian White, go ahead, please.
Yes, thanks, Chair Ferguson. Just wondering if we could just, for the public consumption here, just get staff to give us a brief highlight of the construction update out loud.
Sure,
Mr.
Sure, no problem. No problem through the chair, Ferguson, to Councillor White. Just a brief update as far as the Bayside Center activity report. We had hoped to get the renovatability by April 1st, 2022. Our budget, as far as our costs, we're on target as it states in our report. Our costs, 2022 budget, it was $700,000, and 2021 budget is $3.7 million. And we're anticipating to be a little bit below budget in 2021, but we've got some more budgetary items to fill for 2022 as we basically contemplate the completion of the facility. There have been some COVID challenges because we basically approved this budget before COVID hit, and we're going through that. And we will more than likely be experiencing a bit of a delay as a result of the COVID pandemic. Latest updates has been about 3 or 4 months. So I want to give a county council a brief update on that piece.
Good, thank you. Any further questions with that discussion? All in favor to receive and file? Carried, thank you. Move into any other business. Mr. Meyer, please.
Just to follow up, Chair, sorry, I was able to locate the reference there. That should have read $1 per person for refreshment fee at Heritage Museum. My apologies, we'll have that corrected.
So it's not the good stuff.
Unfortunately not.
Okay, thank you. All right. We will now, any other business for this division? Move into the social service division. Can I have a mover and a second to bring us to the floor, please? Ian Beans, second by Brian White. And I see Valerie Colasanti online. Well, I've heard to a verbal too, also be good for the public.
Actually, oh, I can't hear you.
You're a little quiet with yours, Ms. Colasanti. No, you're not coming through. I do have one question. Maybe Mr. Palecchio can answer this for us. On the debt financing, that will be forward money on this $3 million.
Through the chair, that is correct. That is that money is to be borrowed, but we are through Ms. Colasanti, we're doing our best to basically try to secure other government funding where we would not need to borrow the $3 million. And that's in progress, and we continue to basically pursue any funding envelopes that we can in order to mitigate that potential debt issuance in the event that provincial or federal funding is not there.
Good, thank you.
Let's try this again.
You're good.
Now we're good. Okay, thank you. I've had a recent update, so my apologies. You were looking for a quick verbal update on Maxwell Park Place?
Yes, please.
So in the report, we noted that we had applied for the Rapid Housing Initiative Part 1 last year, and we were not successful in that. We applied again for the Rapid Housing Initiative, and unfortunately, we still were not successful. So as Larry noted, we will need to use a debenture for that. However, construction has started. If you've driven by Maxwell Park Place, you'll see there is some work happening outside. There is work also happening on the development of the modular units, but that's happening at a warehouse. So you won't actually see that. You probably won't see anything for a few months because that work is happening separately inside a warehouse. And then the modular units, parts of them will be brought over to Maxwell Park Place, and then you'll start to see more activity. But work is undergoing. We are anticipating a delay. Originally, we had planned for occupation in May, and now we're looking at September. Similar to other things that you've heard, due to COVID, there is some issues in supply. So it's a little bit delayed, but still certainly on track for, the fall of this year.
Thank you. Now we can open up for questions from the floor, please. Mr. Cook?
Well, I guess you asked the question about the debt financing already, but I just to comment on that, I think right now would be the opportune time, if we are looking at debt financing, to take it on, obviously with rates being as low as they are, even if we have to bite the bullet ourselves rather than get government programming. If we could get some long-term financing fixed up on this, secured through our own personal lender, it wouldn't be a bad thing at this point.
Thank you. I think that fits into some of the remarks made in previous open council meetings on to pre-borrowing money. Any other questions? All in favor to receive this report? Carried, thank you. Any other business for the Social Service Division?
I have nothing else to report at this time. Thank you.
Good. Brian White does have one question.
Yes, thank you, Chair Ferguson. If this is permissible here, or I can certainly ask for a motion and seek an update, but just looking for a brief update, if it's possible, on the temporary housing at the Central United Church site, just to ask if everything is running smoothly there, and how the residents are receiving the service as they would normally be, or are there any issues that the residents are raising at this point?
I'll let Mrs. Colasanti decide if she wants to do a verbal and followed by a report, and we'll see how the satisfaction is at that. Thank you. Go ahead.
Through you, Chair Ferguson, to Councillor White. Thank you for that question. We have started to move individuals to the Central United Church. We've been open for approximately 3 weeks right now. We have capacity for 28, and I believe we have 20 individuals at the residence right now. We've been able to move many individuals from the overflow motel system that we were using. I'd like to remind Council that this is part of the overflow shelter system, so individuals cannot just present at the residence. They are to go through the Ontario Works Office or through the Inn of the Good Shepherd. We do our regular intake, and then it is up to staff to determine where best individuals would go, be it the lodge, be it the central site, or be it our overflow motel site. But I'm happy to report that our numbers are starting to come down. Council will recall that in the summer we were reporting 280 individuals almost presenting through our system, and right now our numbers are down to about 135. So they've dropped significantly because staff have been able to provide the resources to individuals. It's so much easier to provide the services at the central site than it was in a motel. CMHA is there to assist us as well, and we have some other support services. So we are starting to move people into their own housing, which is fabulous. So far it's going quite well, I think.
Thank you. Go ahead, Brian.
Thank you. I just want to extend my appreciation for the work that you're doing on that. I think it's a great thing, and I believe that it truly does benefit the community. So I just want to extend my gratitude and thanks for all your efforts.
Thank you
so much. We'll pass that on to staff as well as the staff at the Inn of the Good Shepherd. Thank you.
Any other questions or new business? Seeing none, I will say thank you for that. And we will now proceed to move in camera. I'll ask for a motion, mover and a second, move in camera. Ian Veens makes a motion, second by Steve Miller. All in favor? Carried. We will give staff time to recalibrate the screens. Thank you, Mr. Tifo. Can you do a rise me report, please, on the in-camera?
Yes, thank you, Chair Ferguson. I'm pleased to report that the committee went into camera for a brief period of time, less than 5 minutes, to entertain two issues concerning labor relations. One, an arbitration award with the SEIU that represents our paramedics, and then secondly, a conditional ratification of a collective agreement with QP 1291 that represents some of our employees at Lambton Public Health. That's all I have to report.
Thank you. Seeing other new business on the agenda, I'm going to ask for adjournment. Motion by Jackie Rumbout, second by Ian Beans. All in favor? Thank you, ladies and gentlemen. That's it for today. And I think Warden Marriott made the statement before it'd be February when the next group comes back in. Thank you, everybody.
Be safe.
Bye.